Hi everyone and welcome back. You have rejoined the COVID-19 update session and I am delighted today to introduce Gabby, who's going to be talking about the nutritional impact of COVID-19, followed by the lovely Dorothy Wade, who's going to be talking about the psychological impact. So Gabby's an amazing dietitian and we are so fortunate again in the UK to work with dietitians across the patient pathway from critical care to discharge. We definitely don't have enough of them, but when we do have them, they're very much valued. So Gabby, I'm going to let you introduce yourself and share your slides. Thank you so much, Gabby.
Thank you, Rachel. I'm going to try and upload my slide first and we'll do a bit of introduction. Oops. Here we go.
Fantastic.
Brilliant. Can you see it?
Perfectly.
Lovely. So, hang on. Okay, good afternoon, everyone. I presume it's afternoon over there in Africa. It's still morning in England and it's a bit cold and chilly. So I'm Gabby Ramlan. I'm actually a diabetes and renal specialist dietitian, but throughout my career and my specialty, I was also trained as an ITU dietitian or ICU dietitian. Hence, I get the chance or the opportunity to work with COVID-19 patients, especially at the height of the pandemic. In fact, at the moment, I'm in standby just in case if I need it on ICU again. So I'm not an ICU specialist dietitian. So thank you so much for the opportunity to share this experience that I had working with COVID-19 patients. So hopefully in the next few minutes, we get to talk a bit more in terms of nutritional management. Just to share with you where I work in London. I'm currently working for North Middlesex University Hospital. Those who are familiar with London, it's in Zone 4 in North Central London, so quite easy access. In the next 20 to 25 minutes, hopefully we get to cover some overview about COVID-19 and nutrition, latest statistic, dietitian role, and nutritional intervention. So as you are aware, and I'm sure that you're very familiar with this now, severe acute respiratory syndrome, coronavirus 2 or COVID-19 has affected the whole world from the beginning of 2020. So for the UK, it's been counted up to or over 1 million positive cases so far, and up to 50,000 deaths has been recorded. It's predicted about at least about 10% of these infected individuals will require ICU admission at some point. And if you look at the population, most of them are pretty much older, above 60 years old. Up to 40% of them have at least one comorbidity, like hypertension, diabetes, heart disease, or even COPD. Some of them obviously has more than one comorbidities, and they even have the term of polymorbidity, which is having more than two comorbidities. About 75% of them are actually overweight or obese. Interestingly, for WHO European region, they also confirmed that between 30 to 70% of European population are obese or overweight. So we are at a very, very high risk of catching COVID-19. And they also see that approximately 10 days from the time someone has the initial symptoms or being infected with COVID-19 will require ICU admission. So we know that COVID-19 causes malnutrition, especially with loss of skeletal muscle mass and function, and may lead to poor outcome. which affecting quality of life and disability. And because of that, they actually rephrase the meaning of malnutrition. And for ASPEN 2020, they confirmed that malnutrition is described as inability to preserve healthy body composition and skeletal muscle mass, which means that even patients who are obese or overweight can also be diagnosed with malnutrition. And we know this very much. As dietitian, our main role is actually to manage dietary requirements to complement the medical condition. And this can be tricky because there's so many things that also come with it when it comes to manage this very poorly patient. And we try to manage this via oral or non-oral intervention. So what I would like to share with you as well is how to identify malnutrition in your patient or your clients. It's been recommended for us to use MUS criteria, which is more community-based. However, say, for example, for my hospital, we actually adapted the MUS screening tool to be used in the hospital. So it's quite simple because you're using the weight of the patient or the BMI of the patient. And then if patient has a significant weight loss in the last 3 to 6 months, that will also consider as a score of malnutrition. And on top of that, if they have any active disease, that will also contribute to the risk of malnutrition. For hospitalized patient, ASPEN actually recommended for us to use NRS 2002. I've included the link in my slide so that you can have a look and use it as well. Recently, they've actually come up with another screening tool by Global Leadership Initiative on malnutrition. For this tool, they actually have 2 parts of the tool. So one is on screening, and the second part is more on diagnosis of malnutrition. How you can do this is by using the phenotypic criteria as well as the etiologic criteria. So if you look at COVID-19 patients, physically, so you're looking at their weight again, those with any weight loss, significant weight loss over the last 3 to 6 months, or they have a lower BMI, or they have reduced muscle mass. So that alone will put them at risk of malnutrition. And then if you look at etiologic criteria, we know that COVID-19 patient actually in inflammation state. So that alone will give them a score to the risk of malnutrition. And then with the effect of taste and loss of smell and also low appetite, that could also have an impact in their intake. And any reduction of intake for more than 1 week will put you at risk of malnutrition. This slide kind of sum up how COVID-19 could actually lead an individual to long-term sarcopenia or cachexia. So as you can see, all the conditions that they experience as a COVID patient will lead to myalgia, muscle wasting, also further inflammation state. And obviously, this will lead to further nutritional requirement. If you look at COVID-19 alone, there is an alteration in their metabolism. There's a higher requirement due to the transmittal of virus, and this lead to a higher energy and protein requirement. And then it also topped up with their medical management, because if you look at, like, they will receive some form of oxygen therapy, sedation, the proning position, and the condition itself, which is a respiratory failure, will actually lead to a higher energy and protein requirement. So these patients, especially if they're on ITU, they will require between 27 to 30 kilocalories per kilogram based on their ideal body weight. The first 3 days of their admission to ITU, we tend to reduce their requirement. So they tend to be hypocaloric, mainly because we don't want to overfeed them, and because we know overfeeding will also affect their respiratory function, because a higher carbohydrate supply will lead to a higher carbon dioxide production. At the same time, if they develop AKI, acute kidney injuries, and some other form of complication, that will further contribute to a higher nutritional requirement. The main important part is to meet their protein requirement, and it's very, very challenging. And I will explain a bit more why it is challenging to meet this requirement. Because if you look at the condition itself, patient is actually in catabolic state, and at the same time, they're not really having any physical movement. So their protein requirement could be increased up to, or at least 30% of their normal requirement. At the same time, they are very, very high risk of developing pressure sore, and I'm sure that you guys are very, very familiar with it. We also play a big role in managing the fluid requirement depending on their urine output and their requirement based on other medical condition that they have. There are certain point that we also see some of them do have many underlying nutrient deficiencies which could not be diagnosed during the critical time. So, challenges to meet patients' nutritional requirement. One of the things that commonly used during ITU admission is sedation, and the most common sedation that we tend to use here is propofol, which is actually a fat base. So every 1 meal of propofol, it will contribute about 1.1 kilocalories, which, if you think about it, is not that much. But if someone who's receiving propofol like 30 to 45 mils per hour, this could contribute to, say, up to 800 kilocalories per day, which actually contribute a very significant amount of calories. So say, for example, someone is on 1700 calories per day, and if they're receiving 800 calories just from fat, so we have to make up another 900 calories with protein. And at the same time, we need to actually manage the protein ratio and to balance it out. And not many feed actually has a very high amount of protein. So it's very, very tricky. At the same time, patient could receive IV fluid or fluid resuscitation, which also contain dextrose, especially if they're on a long-term insulin, and we worried that they will develop hypoglycemia. So patient tends to be on either 5% dextrose or 10% dextrose, which also contribute to another 200 to 400 kilocalories. And these is mainly just sugar or glucose, which means it hasn't got any protein. Again, that will be a challenge for a dietitian to meet the protein requirement. We also know that an IV or C-peptide do contribute to like distension of the stomach, which means that it can affect patients' tolerance to feed. Even to position the tube feed sometimes could cause an air leakage in this process. So there's a lot of complication that comes with it, or we need to weigh the benefits of it. Proning position, it also affects patients' feeding time. So what we tend to recommend is before the proning position, the feed needs to be stopped an hour to 2 hours before, which means that at times patient may miss like 2 to 4 hours of their feeding time, and we need to make it up to another time. Another thing is, in a proning position, we can't feed patient with a very, very concentrated feed because there is issue with the gastric emptying. And sometimes we can start patient on prokinetics to improve their absorption, or sometimes we may move from NG feed, which is nasogastric feeding, to NJ, which is post-pyloric, if they're not tolerating the feed very well. I thought that I include these slides just for those who are not very familiar about the artificial feeding or tube feeding. So instead of these are the type of feeds that we tend to use quite commonly, especially in patient on ITU, and sometimes we do carry on the ward. So artificial feeding actually divided in two categories. One is enteral tube feeding, and the other one is parenteral tube feeding. So enteral tube feeding alone has two parts. So you have the temporary tube and you have the permanent tube. The temporary tube is mainly NG. I think that's probably the most common one that you probably see in on the ward or ICU. So as you can see from the diagram here, NG or nasogastric tube is basically a tube that is placed from nose and directly positioned into patient's stomach. Sometimes in certain cases, we may use via oral, so orogastric tube, if there's issue with the nose. But if the patient is having issues with tolerance, say for example, they have aspiration risk, then we may use a post-pyloric tube, such as nasojejunal tube or nasoduodenal tube. And the permanent tube are the one that's quite common is PEG, or percutaneous endoscopic gastrostomy. As you can see on the diagram, it's directly placed into the gastric or further down if need be. So these are permanent tube. In situation whereby their gut is not working or their GI tract is not working, or there's issues, say short bowel issue or ileus or some other problems, or perforation, we may use parenteral tube feeding, which means we bypass the gut and we give the feed or the food directly into the blood system. For post-ICU admission, obviously we see a lot more complication in terms of nutrition or nutritional related. So the most common one that is people are very familiar with is ICU acquired weakness. And then you'll see patient with dysphagia and swallowing issues because of the tube that they had prior to that. They may continue to experience low appetite, change of taste and smell, and early satiety. In fact, if you've been sedated and unwell on tube feeding for the longest time, you may need to learn how to eat again, and that's affecting your physical ability. Sarcopenia is very, very prominent in this patient. Some of them still required to heal their wound. Say, for example, they develop pressure sore from the proning position or just by lying down. There is also body image issue, which will be interesting to hear what the psychologists will discuss later on, because most of these patients, if they're on ICU, we tend to feed them to their ideal body weight. So chances are they may lose some weight throughout that treatment, and obviously emotional and psychological state. In terms of nutritional intervention, when they are discharged from ITU and go back to the ward, or even discharged from the hospital, sometimes they may continue to be on artificial feeding. So if you're doing any session with these patients, it'd be worth for you either to discuss with the dietitian if they could actually modify the timing of the feeding, because depending on the patient, if they're quite well, we can do overnight feed or we can move things around. So say, for example, I normally give them a break in the morning, so they will start their feeding at midnight and then finish 9 o'clock in the morning, midday, and then we'll finish at 9 o'clock in the morning. So they have like from 9 o'clock to 12 noon to do like rehab and other things that doesn't require them to be attached to the tube. Obviously, we look into if there's any underlying nutrient deficiencies, so we may supplement the patient with certain nutrients or minerals. You may also be familiar that these patients could be on oral nutritional supplements, and the reason why we use the oral nutritional supplements is because that it's more condensed, and these products could range from 125 mils to 200 mils in a bottle, and it carries up to 400 kilocalories and up to 20 grams of protein, which is very hard to have it in a small portion like that if you're trying to get it from normal food. So I try to put like a few different nutritional supplements that we use quite often in the UK, from different brands, just to share you a comparison, because like these products are different. They may sound the same, say for example Ensure, but they have the first name is actually the brand, the second name is the one that actually describes the product itself. So I've put this slide together just to do a comparison in terms of their macronutrients content for each product. So I apologize, I only pick one brand because there's so many of them. I thought if I pick one brand and just to do the comparison so that it'd be easier for you to understand. So say, for example, you've got like Ensure Juice, Ensure Plus, Ensure 2Cal, and Ensure Compact. So Ensure Juice, it's more like a juice base, so it's not milky base. And then you've got Ensure Plus, which is 1.5 kilocalories per meal. And then you've got 2Cal, which is actually 2 kilocalories per meal, and then Ensure Compact, which is actually 2.4 kilocalories per meal. But if you look at the graph, there is like differences in terms of the amount of protein and fats as well, and the amount of carbohydrates. So it really depends on what we're trying to match, or to match the deficit the patient or that individual has, and we will prescribe the nutritional supplements accordingly. If you find you have no access to ONS or oral nutritional supplements, and sometimes maybe you don't have the budget for the trust or the hospital, or actually you're seeing this patient in the community where patient may also have ONS fatigue, which means that they've been on ONS for a long time, they just could not tolerate it anymore and they want something different. So they actually recommend this patient to continue to have extra 400 kilocalories per day and over 30 grams of protein per day to meet their nutritional requirement during their recovery period time. And due to fatigue, we normally suggest them to have more small frequent meal because it's easy for them to manage. I think many people didn't realize that when someone is eating and when you're swallowing something, you actually stop breathing for a while. So that process, if you continuously eating within a long period of time, that could make you feel very tired as well. So small frequent meal is definitely something that we look for. So if you don't have access to ONS, you can also try and suggest your patient or your clients to include extra nourishment from normal food. So I'll put something together here that actually could give you about 200 to 400 kilocalories and up to 20 grams of protein. So something that's quite easy for you to get from the supermarket, or something that you can put together at home. So things like rice pudding, custard, yogurt, cheese. Skim milk powder is very, very handy to have, and it's quite easy to get more calories and protein by using skim milk powder. Those who are vegan, you can always try things like nuts. Obviously, if you have a chewing issue and you find it is a bit of a struggle, you may need to, you can use things like peanut butter, almond butter, the one that is more softer. Or you can have things like tofu, edamame beans. Another thing is it's good to make sure that they have extra 100 to 200 grams of protein sources like meat, fish, lentils, pulses, or even eggs. That would be a good option. So just to summarize my presentation, we could see there is a very high risk malnutrition in these patients, especially during the recovery period. And we all know that the recovery period could go up to 6 months, and their nutritional requirement could continue to be high depending on their medical condition, or if they're still going through trying to recover from their pressure sore. So it's very, very tricky to actually meet the protein requirement. It's quite easy to meet the energy requirement, but to ensure that patient is getting the good proteins, such as high biological value protein in the diet, which consists all the essential amino acid that is very important for the patient, it's very challenging. So if you find that it's challenging, do consider supplementing your patient or your client with some form of nutritional supplements, or to fortify their diet. It is also encouraged, and I'm sure that you're aware about this, that they are encouraged to do 30 minutes exercise for their circulation and well-being. And I think in order to manage this patient with malnutrition, we definitely need a multidisciplinary approach. So physio, speech and language therapies, OT, everybody in AHP, doctors, nurses should be part of the management of this patient. And you can also pick up if you feel that your patient is at risk of malnutrition. Some references that I use for my presentation today, I think Rachel will actually put this in PDF form so that everybody will have access to it. And I would like to end my presentation today with a quotation. Prevention, diagnosis, and treatment of malnutrition should be considered in the management of COVID-19 because it helps to improve the short and long-term prognosis. Thank you.
Thank you, Gabby. That was excellent. And I think from the UK perspective, we really underestimated the nutritional impact of COVID-19 on these patients. As you mentioned, it was multifactorial. We had a high incidence of obesity for patients admitted into hospital, but also those non-hospital admission patients now were seen in the community with long COVID, either had lower levels of activity maybe, or had poor lifestyle in terms of dietary lifestyle, or, you know, smoking history, etc. So a lot of the work we're doing is on behaviour modification and lifestyle changes. Now, there's a couple of questions come in the chat about specifics of diet, because especially if some COVID-19 patients have been told to lose weight, and it's how can you meet the nutritional requirements in that scenario while also trying to be on a calorie controlled diet. So that's probably a talk all in itself for you, but do you have any top tips for therapists out there who might be, you know, making suggestions?
So I think there are two different parts of it. So you want patient to lose the weight because that will be healthier for them, but also to how to meet the nutritional requirement. In these type of patient, the most important thing is we need to meet the nutritional requirement based on their ideal body weight. So if you have an access to dietitian, that will be brilliant. But if not, it will be good to just calculate like what they need as to meet their ideal body weight. So that will ensure that they have a balanced diet, like they will meet all the requirements. It will minimize the risk of deficiencies. So at the same time, because if their calorie allocation is based on ideal body weight, then it will also help them to lose weight healthily and meet their protein requirement because it's based on their ideal body weight. So yeah, hopefully that kind of gives a bit of a gist. So you can work out your ideal body weight based on BMI. So if you know someone who's actually BMI above 25, what you can do is get their height. So height times height squared, which is height times 25, i.e. BMI. So you will get their ideal body weight. And from there, normally most people will need about 25 to 30 kilocalories per kilogram of ideal body weight. And that will give an approximity of how much they need per day to work out their calories.
Okay, that's fascinating, amazing. I think we could speak to you all day, and thanks so much for your perfect timing. So Gabby's more than happy to be reached out to on Twitter. So please do interact with her. If you've got any more questions, just check in the box. No, nothing else. So thank you so much for your time. Really appreciate it.
Thank you, Rachel. Have a good day.
Bye.
Bye.
So our next speaker has been patiently waiting in the background. So Dorothy Wade needs little introduction. She's the most fantastic clinical psychologist, and she has got a very specialist interest in critical care. And I'm delighted that she's agreed to join us today. So Dorothy, are you okay sharing your slides? We do have a bit of a backup. And Dorothy's going to introduce herself because she's got a lot of experience in this field. And I believe in Africa, if not around the world. So Dorothy, over to you. we're having a slight delay. So there we go.
Yeah, can you hear me now?
Perfect. We've had some technical difficulties all day. Some of it's down to Zoom as well. So thank you so much, Dorothy.
Can you see the slides?
Yes, perfect.
Can you see all of them? Yeah.
Yeah.
Okay. Thank you very much, Rachel, for introducing me and asking me. I'm very excited because I spent 2 years in Africa after graduating as a teacher and doing some reporting. So I always take a great interest in everything that's going on in Africa. So this is exciting for me. But currently I'm Principal Health Psychologist in critical care at University College London. I'm also an Associate Professor at University College London. And I've been lucky enough to co-lead the British Psychological Society Guidance Development Group on meeting psychological needs of patients with severe COVID-19. And I've also been contributor of the psychology perspective to other UK groups on rehabilitation of COVID patients. So my talk is just really based on my own experience in the hospital during the first wave of the pandemic we had here from March to, say, July, and then sort of literature that's come out from UK, China, Italy, other countries who've been looking at psychological outcomes. But I always like to start with something from the patient experience, because they are the ones who actually know what it's like to have severe COVID-19 illness and what the impact is. So the first patient I was going to talk about was a patient who was in hospital in ICU for 14 days. And that was a Arabic-speaking patient called Abdul, who was treated with CPAP, mask ventilation. And he had a very harrowing time. He said, "It was like a horror movie. I felt sorry for the nurses. They had no time even to wake us up. They'd just start to take blood. I was dripping with sweat, but there was no time to clean us. I still get very tense and upset thinking about the tight mask. I've had nightmares and many upsetting memories. I saw emergencies, dead and dying people. There was a woman who screamed all night." And of course, Abdul has given me permission to use the quote, but I've changed his name and details. But it was also a really frightening experience for a patient who might not have been sick enough to be taken into hospital, so was at home. And this was the experience of a young woman called Jade, who is age 32, lives alone, has asthma, and seemed to be experiencing COVID symptoms for a long time, what people are now calling long COVID. And this was a quote she gave to the BBC in September. "I was just going hot and cold and coughing and coughing and coughing. I ran for an ambulance. The paramedics came and spoke to me through the window and told me they couldn't take me to hospital because I was young and should be able to cope. I was just left. I felt so poorly and I was so scared. I was even too scared to go to sleep at night in case I didn't wake up." She would start recovering and feel better, but then the symptoms would return. "My chest got really bad again. I was struggling to breathe. I've never experienced such fatigue." So what are some of the factors that were contributing to that psychosocial impact of COVID-19? Again, I've looked at the hospital and the home situation. So in hospital, some patients were awake and some patients were sedated. So they, at different times, they had a different experience. For awake patients, they might be scared because they could see there was a lack of staff. The staff they could see were dressed in full PPE, masks, visors, and so on. You could hardly see an inch of their face, so that was very scary and made for difficult communication. Awake patients like Abdul witnessed suffering and death of other people. We didn't allow any families into the hospital during COVID time, so they were separated from their family. And conditions were quite poor. We were sort of deluged with cases, so we had people crowded in together into kind of dark, airless areas at times. And some studies have found that 96% of patients in that situation had acute stress and fear. For sedated patients, many of them underwent really prolonged ventilation in that first wave of COVID. And going along with that, they had a prolonged period of being sedated and were more deeply sedated than we would normally want. And we were also using more deliriogenic sedative agents that normally we might not choose to use, but there were drug shortages and we were using what was to hand. Patients were proned, which seemed to be good for their breathing, and paralyzed on the ventilator, and there are some cases of awake paralysis. And other studies have found that more than 60% of COVID patients in ICU were confused, agitated, and delirious. Patients at home had the psychological challenge of managing breathlessness and also delirium. It was not just hospital patients who were delirious. Many patients at home had that same experience. Without support from any healthcare staff, they didn't really have, nurses and doctors around to ask advice. They were having their symptoms recurring, so they wondered if they'd ever get better. They were very lonely at home, very anxious. They were frightened of contaminating others. They were frightened of the stigma of having COVID-19. And this was in an atmosphere of societal panic and lots going on in the media to keep people's anxiety levels very high. So what were the psychological outcomes of these experiences? These are all 2020 COVID-19 data. Neurological cognitive effects were reported while people were in the hospital, such as encephalopathy, stroke, dementia-like state, and cognitive impairment, such as in memory or concentration or attention. However, we don't know if these were just short-term effects. The long-term effects are still unknown. In terms of the more emotional psychological outcomes for patients coming out of hospital, 1 month later, 28% seemed to have PTSD symptoms, 42% had anxiety, and 31% had depression after having COVID-19. And these are quite similar to the rates actually that we would see in a general critical care patient leaving hospital, perhaps a bit higher on the PTSD rates. And as you might expect in UK, there was worsened anxiety and depression at 4 to 8 weeks among the ICU patients versus those who were in hospital but not admitted to ICU, with a difference of 38% versus 16%, quite significant. But again, there are psychological consequences for people who were in the community. We're hearing more and more about long COVID, something which seems to involve anxiety, breathlessness, chronic fatigue, cognitive effects, and definitely heightened health anxiety. Depression and anxiety in the community have found to be high. In fact, when you compare recovered patients to the general public seem to have worse levels of depression and anxiety, 34% even than the recovered patients. And obviously those people who are in quarantine, they seem to feel a bit more protected. So they were sort of 10% prevalence of depression and anxiety. We don't know too much about risk factors yet, but having looked at the sociodemographic risk factors in one study, they found no difference in post-traumatic stress disorder prevalence between different ethnic groups. However, they found much higher rates of post-traumatic stress disorder in women than in men. So what can we as healthcare professionals and psychologists in particular do to help? This triangle pyramid here summarizes the British Psychological Society recommendations. So we were recommending at the bottom level, the most basic for everyone, was provision of information and good psychological care. For those who are having difficulties, we recommend structured rehabilitation and self-management. That would be multidisciplinary team with a psychologist embedded in it. But finally, specialist psychology services for the smaller group who are more seriously affected long time. So what does good psychological care look like in the hospital? We think that all patients with severe COVID-19 should receive psychological care as well as patient-friendly information. And this doesn't just come from psychologists, all staff working in COVID areas should receive some training in delivering what we call psychological first aid. And that's a way of making patients feel safe, calm, connected, confident, and hopeful, even though they are in a difficult situation at the moment. Training also to help patients relieve fear and help them understand their own reactions, such as anxiety, panic, low mood, as well as understanding about delirium and other clinical conditions that may be having a psychological impact as well as physical. And to be able to manage critical care patients who are agitated and distressed and having hallucinations, which is very common in critical care and was very common during COVID-19. There should be the possibility of referring to psychologists in the hospital for the more complex cases. And it's good to have any resources that you can lay your hands on to distract and entertain patients, whether it's iPads, whether it's a radio, whether it's their phone. You can find some relaxation and music apps on there, whether it's, you know, just having a family photo by their side, anything that can just help to make it a slightly more humane experience for patients. And if you're interested in this, there's guidance for staff in psychological care available via the Intensive Care Society. That's UK, but I think it's available to everyone. And that's the website there, www.ics.ac.uk. These are some of the resources that are on that website, which myself and colleagues put together. So, for example, we created a COVID information sheet for awake ICU patients. So it's very, very simplistic, but it was really for people who were just waking up out of sedation with a kind of bit of brain fog and confusion and not really knowing where they were or why they were there. So we tried to give some very simple information to help them begin to understand where they are and what some of the treatments they're receiving are and what the meaning of the symptoms are, and even why they might be having nightmares or very scary thoughts. It's very useful to get some information about that you can understand. We've got some staff guides to the psychological care of COVID-19 critical care patients available on that website. The first page there, that really looks at what issues you might need to know are affecting your COVID-19 patients. So obviously fear and anxiety, that was very prominent. The fact they feel isolated, the fact that everyone they see is wearing PPE, they can't see anyone's face and they often can't really hear what you're saying. For some, it's the fact that they are or were ventilated, sedated, proned. Delirium, of course, is very prominent in critical care patients and COVID-19 patients. And that's often, apart from making you feel confused and disorientated, it is often accompanied by really frightening hallucinations, delusions, and maybe a feeling of paranoia that there's a big conspiracy against you. But of course, luckily, some people feel positive emotions too. I've seen patients sort of crying with gratitude that they survived and for wonderful humane care that they received from our staff. But there is another issue in being awake and aware, in that you might witness all sorts of things that might be very frightening to witness, as Abdul was telling us about. We promote something called psychological first aid, and psychological first aid is good psychological care for people after they've had a frightening or traumatic experience, such as admission to hospital with COVID-19. And we say that those people have 5 main needs. They need to feel safe, they need to feel calm, they need to feel connected to others, they need to feel some confidence and control, and they need to feel some realistic hope. And this is a sort of tip sheet to tell you some of the different ways that any staff could contribute to helping patients feel that way, feel safe and calm. The third and last guide is really telling you about what a psychologist could bring to bear, as well as the psychological first aid, which all staff can do. And it's telling you a little bit about the elements of a psychology care session with a COVID-19 critical care patients. So some of the things we might be trying to do would be just giving patients a chance to open up about any experiences, any worries or fears that we might have. We wouldn't be probing to ask them to say anything they don't want to say, because that can actually traumatize people. But sometimes it's just good to listen to whatever it is that patients want to tell you about, and just to have the time to sit there and listen. We can help to normalize common reactions, such as, explaining that, a lot of patients obviously feel very stressed when they're in intensive care. Sometimes people feel a bit confused, partly because of the drugs and partly because of the environment, and telling them about the fact that some people do have unusual experiences such as hallucinations. So that might just help them to hear that, oh, other people have been going through a similar thing to me. Maybe there's a reason for it. Maybe it's not just that I'm going mad, as many patients fear. Explaining some of the causes of these common emotions and experiences in critical care. So again, you might tell them about the effects of certain drugs that they might be given, including opioids or benzodiazepines and other drugs. And then there are obviously the other factors in the environment, and it's useful for patients to begin to piece that together. You might try and teach new coping strategies such as relaxation exercises and breathing exercises, but at the beginning that can be quite difficult for a patient to learn anything new. So you might just try to find out any coping strategies they normally use themselves and encourage them to use those to keep themselves calmer, even if it's just listening to some calming music that they've maybe got on their phone. And encourage them to ask questions and get information from the staff, because often people are a bit frightened to ask, and sometimes the staff forget to give them that information. Think about, a lot of people are making themselves even more stressed because they're having very stressful thoughts. So they're thinking, like I said, they think I've gone mad, or they think I must have brain damage, or they tell themselves I'm never going to get out of intensive care. I haven't made any progress, even when they have made progress. Anyway, so on. There are several techniques that a psychologist might be using. And as I mentioned before, it's good to have resources, anything you can to distract, entertain, or relax patients. So that could be iPads or any kind of devices, using well-being meditation and mindfulness apps, communication aids, even if it's just an alphabet chart on paper to help them talk, those who can't talk, breathing, relaxation, and peaceful exercises. And maybe just ask patients what they would like, even if it's a newspaper or something that would just help to break up the time for them and make them just feel a little bit more settled, and see if you can provide that. This is back to the British Psychological Society guidance. They're saying that before leaving the hospital, patients should receive both verbal and written information from the hospital team about the journey they've had so far, but also looking forward, they should have an individualized rehabilitation and recovery plan that they understand, and hope ideally given to them in a folder to take away. They should know the causes of any remaining symptoms, and letting them know that often symptoms will improve with time, but also what to do if they don't improve. But what we find is sometimes patients still believe they're very seriously ill because they still have some symptoms, and they don't really understand that it's normal to have some symptoms at this point, such as breathlessness, and how that might improve and what to do to improve it. And we also give them a booklet about common difficulties with physical, psychological, or functional recovery that they might encounter during hospital and what to do about them. So you can see the booklet in the corner there. And of course, it shouldn't just be a one-way street of us telling them stuff. They should also be encouraged to ask questions about anything they're still worried about, any symptoms they have, or things that happened in the hospital that worry them or that they can't recall. It's quite good if some of those can be dealt with then and not just left till some later appointment. And they should also, maybe they don't really understand their recovery plan, and they don't really know who would they contact for help if it wasn't going well. So again, we should give them the opportunity to ask those questions. What we're trying to do in the UK is make sure that all patients recovering from COVID-19 should be proactively followed up after 1 or 2 months after discharge. And that's people who were in hospital, but also people who weren't in hospital. So this follow-up, it might come with the family doctor, or they might be able to go to a hospital-based follow-up clinic to review all their psychological, functional, and physical needs. Ideally, relatives should be invited because they've been through a difficult experience as well, and both need to understand something about the other's experience. So they should be given the chance to speak and ask questions about, the experience they had in hospital, including unusual memories. A lot of people at this point bring up the strange hallucinations they had. And they say it's really strange. I was traveling all over the world. I met President Trump. I don't know if he's still president, or Tony Blair. They meet all sorts of people, but they also are really worried that they might not remember several weeks because they were sedated. And if they can discuss that with healthcare professionals who really understand the experience of severe COVID-19 in critical care, that can be really useful. If possible, try to do a brief screening for various elements that are going to affect their recovery, both physical and psychological recovery at the appointment. And these are just a few examples of ways to do the screening. It's important to see if they are taking up their daily routines, including their sleeping and waking routine, because a lot of people's sleep has been disrupted in the hospital. Evidence that they're returning to normal activities, impact on family and other relationships. And we normally screen for anxiety with something called GAD-7, low mood with PHQ-9, post-traumatic stress symptoms with the trauma screening questionnaire, and cognitive difficulties, and for example, with the MOCA. And I'm happy to give more details of some of these screening instruments, offline later if anybody wants to contact me. So for patients who are screened and it's found they do have some significant difficulties, whether it's psychological or functional, we recommend access to a structured multidisciplinary rehabilitation package. Ideally, this should be an integrated service which involves all sorts of different relevant multidisciplinary team depending on the specific needs. But ideally, there should be availability from physiotherapists, occupational therapists, psychologists, nurse specialist doctors, and many other professions, including dietitians or speech and language therapists, for example. Given that we can't always see people face-to-face, then people can be offered to do this remotely, by phone, by video, or in some cases, we still are seeing people face-to-face. We want to build in an element of peer support with this, and we have the involvement of patient-led organisations. So a lot of patients find that the best people to talk about this experience is other patients or families who've been through the same thing. And again, I mentioned it's really important for the patient's rehabilitation to involve their relatives and loved ones. The key sort of more psychological aspects of that package include providing information and education to normalise psychological symptoms and explain some of the causes. We use cognitive behavioural approaches to recovery and to managing emotions such as low mood and anxiety, panic, anger, whatever it is. We use interventions to increase people's confidence in resuming their normal life and overcome their fear of just getting back to some normal activities. And where people have cognitive problems, we can give some advice on compensating for those problems. Finally, the specialist psychology services are just for those with very clinically significant difficulties with depression, anxiety, post-traumatic stress disorder, or other psychological difficulties. Here in the UK, that might involve referral to local community psychological therapy services, which are not always that easy to get referred into. We have a big backlog and a big waiting list for all of those. Or sometimes you can provide psychology services with physical health psychologists, critical care psychologists like myself, or psychologists specialising in traumatic stress, where available. But again, there can be a very long waiting list for some of those services. And if people have significant cognitive difficulties, then we would be trying to refer them to specialist neurorehabilitation and or neuropsychology services. And again, those services aren't always available as we'd like to be. So what we quite often do is we're just trying from the hospital to keep supporting people as best we can while they're trying to get onto access to those services. These are just a few resources and services to tell you about. So the document below here, meeting the psychological needs of people recovering from severe coronavirus, you can find that on the British Psychological Society website, which the website address is given there. In the UK, as I said, there are hospital outpatient COVID respiratory and long COVID clinics and critical care follow-up clinics. That's a resource that some hospitals in the UK have, not all. But something that everyone can actually get hold of is this really good new NHS website, which I think anyone anywhere in the world can access, which is called www.yourcovidrecovery. And that's a website, an interactive program that has just been designed by multidisciplinary experts. So you can go into that and really anyone who's suffering from, you can recommend to your patients or anyone you know who's having difficulties that they can go in there and find all sorts of resources. This is the page, supporting your recovery. This is their cover page after COVID-19. And you can see across the top, there's the tabs telling you what is COVID-19, how to manage the effects, your well-being, your road to recovery. And there's everything on there, psychological, physical, all sorts of different tips and ways to help your well-being. And there's also a special section, as you can see below, with information for family, friends and carers. So I would just urge everyone to have a look at that and recommend it to people, because yeah, it's been written by experts, but it's written in a really nice patient-friendly way. As far as I can see, it looks really useful. Okay, so that's the end of my talk, and I just wanted to thank all the staff and patients of University College Hospital Critical Care. So they're the ones that have taught me everything I know. Also David Murphy, who last year was the president of the British Psychological Society and now the vice president. We worked together on a lot of the resources and he was amazingly supportive. And then just to let you know that there's an organisation of psychologists who work in critical care in the UK called Pink UK, and that is our address, email address. So please, we'd love to link up to people anywhere in the world, I think, and we're happy to answer requests and try to connect you up with anyone that you might want to be connected to. So finally, that's my email address. I'm on Twitter as well. I think I'm at dwadepsych, and I'm happy to answer any questions in the 2 minutes that are left.
Thank you, Dorothy. That was incredible as ever. We do have some questions in the chat here and also DMs. So, and there may not be an answer to this, but are there any psychological approaches to help people when they have hypoxic confusion? Is there anything you can do in that situation?
I think it's just trying to stop them feeling very scared and agitated. So there's a lot you can think about in terms of tone of voice when you're speaking to people like that, your body language when you're speaking to people like that, the way care is delivered to them, not crowding them. So I think it's just ways, and just trying to think about their emotional well-being until maybe things start to settle. If the confusion, there's not much you can do about the confusion until it does start to clear, if it's going to clear. And then there are quite a lot of ways you can help people to reorientate and start to use some cognitive strategies to help.
Definitely. And I've just put in the chat about sometimes if patients are so confused they're in their full ventilation, that might be the most appropriate strategy, or sometimes medication can be useful in that situation, but used with care and caution. And it's that, and it's the team approach with regards to, is this delirium? Is this confusion? Like what is this as well?
And we don't always know at first, but it's good to investigate what it is. Is it really hypoxia, or is it, hopefully not hypoxia, but it's quite a temporary delirious state?
Yes, and we've talked at length about the debilitating consequences of hypoxia, both in the acute and long-term phase. Now, we did have questions in some of the other presentations about psychological support apps. We're in this digital virtual world now. I know you've signposted to some websites. In the second part of that question is mindfulness and the mindful apps that can help with the anxiety associated with having COVID and also having survived COVID as well.
Yeah, I mean, mindfulness. I mean, mindfulness is a very useful practice. It depends how far you want to take it. Ideally, you can do a whole mindfulness course that lasts 8 weeks, and you can do that online, I think, if you really, really want to sort of take it seriously. If you just want to listen to some calming apps, then I think there are many, many available, whether it's Headspace, there are lots on YouTube.
Do you have a go-to app, I think is what people were asking? Would you have one you'd recommend over others that people could just have a quick look at?
Probably Headspace, yes.
So Headspace app for those of you that were asking. Now, this is a great question. What do you think about virtual peer support groups for those in the community? So online, I mean, we done a whole session last night on patient experience of COVID, and that was one of the big things that each one said. Facebook groups, what do you think about that? Is the pros and cons?
Yeah, I mean, mainly I think it's a great thing because I'm really in favour of the ICU steps type groups, which are patient and family support groups for former critically ill patients. Normally they would meet together, and of course at the moment they can't meet together. So I know a few groups are set up a virtual support group. We're just in, one of our patients and another psychologist here is in the process of setting up our virtual support group. So I mean, most patients say that one of the most useful things for them is just being able to share these very strange and frightening experiences with, the only other people who can truly understand that, who are other patients and families who've been through the same thing. I can see there could be some worries and concerns about if somebody gets very distressed during a call. You're not, normally I would be in the room with people and I would know, I would be able to leave the room if they left the room, given we would normally be co-facilitating. I'd be able to check up on people later. But I think this way I'll be able to check up, we'll probably have some kind of register, we'll know who was there, we'll be able to see everyone on camera. And I will probably be able to check up on people afterwards, and I'll encourage people to get in touch with us if they do feel triggered or upset by anything that happened within the support group. And obviously we're going to just have to be very careful about confidentiality and giving out people's, how people opt into the group and keeping their information safe. Does that cover the main kind of points? Yeah.
Absolutely, that's incredible. So this will be available to view after the session as well if you want to signpost any of your colleagues to this wonderful presentation. Dorothy's left her email address up there, which is very